aspirants. Today's class is about debriefing on mega mock test, which you all people did in your portal, and it would be conducted by Dr. Ashutosh Kumar Garg. He is head of department in Kailash Deepak Hospital, Delhi. His area of interest is in mechanical ventilation, hemodynamic monitoring, renal replacement therapy, and nutrition. Over to you, sir.
Very good evening, everyone. Today we are going for a mega mock test, EDIC 1. So initially, I will ask type A question. You can give your responses in your chat box. So first question is in front of your screen. So this is a 35-year-old woman is evaluated in the emergency department for fever, severe epigastric abdominal pain and nausea, and have worsened during the course of 12 hours. She denies any medical history. Her father has a history of gallstone. Vital signs are temperature 101.1 degree Fahrenheit, heart rate 115 beats per minute, blood pressure 90/60, respiratory rate 19 breaths per minute, saturation 93% on 2-liter nasal cannula. After blood is drawn for laboratory testing, she is given 4 liters of ringer lactate over 4 hours. She is also being given IV morphine for pain and vancomycin cefepime for fever. Abdominal ultrasound is equivocal for gallbladder wall thickening but shows pericholecystic fluid and dilated pancreatic duct. The pancreas appears inflamed but no necrosis or cyst is noted. Critical care service is consulted for severe pancreatitis. Vital signs after 4 liters of crystalloids are temperature 102, heart rate is 109 beats per minute, blood pressure 110/75, heart respiratory rate 22 breaths per minute, saturation 91%, lab test showing urea BUN 45, creatinine 1, SGOT 235, SGPT 129, amylase 2023, bilirubin 2.9, lipase 4320, WBC count 14,000, hemoglobin 15.5, hematocrit 47%, platelet count 4.5 lakhs, and lactate is 2.1. So which of the following principle applies to this patient management? Immediate CT with contrast will provide most prognostic information. Empiric antibiotics should be continued because they will decrease the risk of death. Initially, she should be given bowel rest because enteral feeding may worsen prognosis. Chest radiograph may be helpful in determining her disease predicted mortality at 30 days. Further IV fluid will decrease her risk of death. Somebody has given answer D. Anybody else? D. D. What is the logic behind it?
Bicep score.
Yes, absolutely right. So bicep score is for the prognosis of the acute pancreatitis. And in bicep scores, what are the full form of bicep? BUN more than 25, I for impaired mental status, S is SIRS, response age more than 60, and pleural effusion. So in bicep, the pleural effusion, if you want to see the pleural effusion, you have to go for the chest X-ray. And rest all, we know IV fluid, we already given 4 liter. Chest radiograph will helpful for prognosis because of bicep score. Bowel rest, there is no role of bowel rest because early enteral feeding is guidelines. As per the guidelines, early enteral feeding should be started. Antibiotic should be continued. And immediate CT with contrast will not provide prognostic information at this point of time. Is there any confusion? Should we go ahead? So next question is 55-year-old man with a history of hepatitis C and alcoholic cirrhosis admitted to ICU from ED with suspected upper GI bleed. He has a history of esophageal varices requiring banding. He started on PPI and octreotide in ED and gastroenterology was consulted. Soon after arrival in ICU, he decompensates with copious hematemesis and become hypotensive. An upper endoscopy for source control is not available. In addition to continued resuscitation while awaiting gastroenterology, which of the following is most appropriate management? Place a NG tube, start antibiotics for SBP prophylaxis and low dose beta blocker to decrease portal venous pressure. Intubate for airway protection and place a Blackmore tube for hemorrhage control. Place a Blackmore tube for hemorrhage control, start antibiotic. Intubate for airway protection, place a Blackmore tube for hemorrhage control and start antibiotic for SBP prophylaxis. So answer given by you is again D. Anybody? All are on the same page. Answer should be D. But answer is E. E for elephant. Intubate for airway protection, place a Blackmore tube and start antibiotics. Sorry, not D. Oh. I thought last option is E, but there are only 4 options. So answer is D, absolutely correct. So last option is intubate for airway protection, place a Blackmore tube and start antibiotic. This is the answer. Okay, so answer is D. Okay, is there any confusion? You can ask.
Sir, is it necessary to intubate the patient for putting up the Sengstrand Blackmore tube?
Yes, because patient cannot tolerate this tube. So for putting this tube, patient should be intubated, sedated and paralyzed. And one more reason, patient may aspirate also blood. So that's why we should intubate the patient. Okay. Next question. A 24-year-old woman with a history of depression is brought to the emergency department for lethargy and confusion. Patient was last seen by family about 8 hours ago. Emergency medical service personnel has found an empty bottle of acetaminophen at the scene. GCS is 10 but hypotensive. 2-liter bolus of IV fluid to stabilize her blood pressure. Laboratory findings are SGOT 54. SGPT is 32 and alkaline phosphatase 110, albumin 3.8, INR 1.2, lactate 1, ABG reveals pH 7.35, PCO2 35, PO2 95 and acetaminophen level is 400. ECG showing normal sinus rhythm, which is the following most appropriate next step in the patient management. Answer is E. E. So 3 or 4 persons have given the answer E, and this is absolutely correct. For paracetamol toxicity, and if level is 400, then definitely you should start with the N-acetylcysteine. So N-acetylcysteine replenishes the depleted glutathione reserve in the liver and enhances non-toxic metabolism of acetaminophen. So patient with acetaminophen or paracetamol overdose are stratified according to the Rumek-Matthew nomogram. Okay. So if a patient has taken a massive dose of acetaminophen more than 30 gram or serum acetaminophen level greater than 500, then a patient should be transferred to a liver transplant center for urgent evaluation of possible impending liver failure. So next question is, a 38-year-old man previously in good health presented with hematemesis, no history to suggest liver disease, gastric esophageal varices, bright red blood is aspirated after placement of NG tube and is not cleared with 500 ml of saline lavage. Which of the following is best first step in the management pending diagnostic endoscopy? Continuous infusion of vasopressin, continuous infusion of H2 blocker, proton pump inhibitor, administration of sucralfate and H2 blocker in sequence, administration of FFP. So your choice is D, means administration of sucralfate and H2 blocker in sequence. So answer is C, because peptic ulcer is the most common cause of acute upper GI bleed in hospitalized patients, and PPI are frequently used as a part of initial management. So we start the PPI infusion when endoscopy is planned. But issue is that if initiation of treatment before endoscopy decrease the stigmata of bleeding shown and no effect on bleeding, transfusion requirement, need for surgery or mortality. So pre-endoscopic PPI therapy may be most beneficial in instances of delayed early endoscopic treatment on when available endoscopic expertise is limited or suboptimal. So understood. So if endoscopy is available, then best thing is go for the endoscopy and don't start H2 blocker infusion. If endoscopy is not available, then you can start the H2 blocker. Otherwise, because of the H2 blocker, gastroenterologist cannot see the stigmata of the bleeding or from where the bleeding has started. So that's why if endoscopy facility is available, then go for endoscopy. Don't start H2 blocker or PPI. And among H2 blocker and PPI is the best thing to start with. Okay. So compared with either placebo or H2 blocker, PPI treatment significantly reduces rate of ulcer rebleeding and surgical intervention. So this is very important to understand. If they have given in the option endoscopy is available, then endoscopy is the best. If endoscopy is not available or expertise is limited, then you can start the PPI infusion. 42-year-old woman has a 2-week history of nausea and vomiting. She had bariatric surgery 2 months ago. She reports generalized weakness, fatigue, confusion, weakness of the lower extremities associated with numbness in both hands and feet and blurry vision. Physical examination shows sinus tachycardia, horizontal nystagmus, and peripheral neuropathy with muscle weakness and decreased reflexes. The most important next step is IV administration of
Thymine.
Thymine.
So what is your take? Why it's thymine?
It's
After
Wernicke's.
Absorption of thymine is decreased due to
Sorry?
bariatric surgery.
Sorry? Please repeat.
For the bariatric surgery causes the deficiency in thymine because of less stomach is available for absorption of thymine.
Okay. So basically, what is the diagnosis here? Wernicke's encephalopathy.
Yeah.
So thymine deficiency is rare but commonly in bariatric surgery. So in nervous system involvement, it is called dry beriberi. Neurological finding can be peripheral neuropathy characterized by symmetrical impairment of sensory, motor, and reflex functions of extremities, especially in distal lower limbs. So peripheral neuropathy in thymine deficiency, it presents as a subacute motor axonal neuropathy mimicking like GBS. So another neurological involvement is Wernicke encephalopathy, in which vomiting, horizontal nystagmus, palsies of eye movement, fever, ataxia, and progressive mental impairment leading to Korsakoff syndrome. So prognosis is good because it responds to the thymine replacement. Okay. Next question. A 44-year-old 60 kg woman is admitted to ICU, intubated and ventilated after being admitted with community-acquired pneumonia. She remains intubated and ventilated 48 hours later. She is on 70% oxygen, receiving a 0.02 microgram per kilogram per minute NORAD. Full enteral feed, and she is sedated with propofol and fentanyl. Regarding stress ulcer prophylaxis, the most appropriate management plan is?
No prophylaxis needed.
No prophylaxis is needed
Yes. Why?
because she is on enteral feed.
Full feed, full and
Full
Full
feed.
feeds.
So whenever patient on full enteral feed, so no prophylaxis is required for the stress ulcer. Absolutely right. So the most important thing for the stress ulcer disease are two important things they ask in the question. One is coagulopathy, another is mechanical ventilation for more than 48 hours. These two are the important risks for the stress related mucosal damage, SRMD. So if patient on mechanical ventilation for more than 48 hours and there is a coagulopathy, then you have to start the H2 blockers or PPI as a stress ulcer prophylaxis. But if patient on the full enteral feed, then patient does not require any stress ulcer prophylaxis. Next, a man is admitted to your ICU with acute liver failure. Which of the following criteria must be met to fulfill a diagnosis of ALF? Illness duration less than 28 days, presence of CLD, jaundice, coagulopathy, encephalopathy.
Coagulopathy.
Okay. Any other answer? Encephalopathy is the answer. Because the criteria for the ALF is the absence of CLD, acute hepatitis shown by the AST or ALT ratio, and increase in the INR more than 1.5 means coagulopathy, but along coagulopathy along with the transaminitis. Any degree of mental alteration, encephalopathy, or illness less than 26-week duration. It can further subdivided into hyperacute, acute, and subacute, depending on the time from the initial insult of under 7 days, 28 days, 26 weeks, respectively. So, for diagnosis of ALF, encephalopathy must be there in any grade. So, what is the criteria for the grading of encephalopathy in the acute liver failure? What is the name of that criteria? Can anybody tell? West Haven criteria. So West Haven criteria for the grading of encephalopathy. Then regarding the Sengsten Blackmore tube and use in upper GI variceal hemorrhage, which statement is true? It has 4 ports, must be stored at 4 degrees centigrade, require insertion via the oral route. Rebleeding is common after deflation of gastric balloon. The tube should be removed within 12 hours of insertion to prevent pressure necrosis.
C.
Rebleeding is common after deflation.
rebleed, yes, rebleed is common after deflation.
In 50% cases, after deflation of gastric balloon, there is a rebleeding. So answer is D. And it has 3 ports. Minnesota tube has 4 ports. Okay. So you should know the difference between the Minnesota tube and the SB tube, Sengsten Blackmore tube. And it stops the bleeding in 90% of cases. But rebleeding may occur in up to 50% of cases on deflation of the balloon. And it is recommended to be removed within 36 to 48 hours, not in 12 hours. Then next question, again on the Sengsten Blackmore tube. Which statement is false? 80% of the patient will rebleed once the balloon is deflated. It is effective at controlling torrential bleeding from esophagogastric varices. It has 3 lumens. Insertion at the 55 centimeter mark at the incisors indicate the gastric balloon position is below the gastroesophageal junction. Esophageal balloon must be deflated every 4 hours.
A, 80%. Just now you told 50%.
Yes, just in previous question we have discussed that 50% of the patient will rebleed once the balloon is deflated, not the 80%. So answer is A, up to 50% of patient will rebleed following SPT deflation. It is effective at controlling torrential bleeding. It has 3 lumens, 1 for balloon, esophageal balloon. gastric aspiration and gastric balloon. And 55 centimeter incisor indicate position well below the gastroesophageal junction. And every 4 hours for 15 minutes, we should deflate to reduce the potential mucosal damage.